I am Dr. Lokesh, Professor, Department of General Medicine, Sri Siddhartha Medical College, Tumkur. I am taking topic fever and fever of unknown origin. Introduction about fever. The hypothalamus controls the body temperature. Neurons in preoptic anterior hypothalamus and posterior hypothalamus. This receives two kinds of signals. Okay, from peripheral nerves that transmit information from warmth or cold receptors in the skin from the temperature of the blood bathing in the region. The thermoregulatory center of the hypothalamus integrates these two types of signals to maintain the normal body temperature. The hypothalamic thermoregulatory center, it balances the excess heat production derived from metabolic activity in the muscle and the liver with heat dissipation from the skin and lungs. So, normal body temperature is 35.3 to 37.7 or 95.5 to 99.9 degree Fahrenheit. Rectal temperature are generally 0.4 degree higher than the oral readings. The right atrium is an ideal site of measuring core body temperature because it is the nexus at which venous blood from all anatomic regions joins. So, how does normal body temperature regulates? So, preoptic anterior hypothalamus, warm sensitive neurons, different pathways, it goes to hypothalamus, brainstem, spinal cord and sympathetic system. So, thermo effectors like vasoconstriction, vasodilatation, shivering or sweating or your brown adipose tissue thermogenesis, thermoregulatory behaviors, this in turn is going to lead to peripheral temperatures and peripheral sensors. So, afferent signaling, dorsal root ganglion, spinal cord and brainstem, it is going to once again go to preoptic anterior hypothalamus to regulate the temperature regulation. Next is we have got thermoeffectors is going to core temperatures and once again it go to preoptic anterior hypothalamus. Our core temperature extra brain core sensors, inter preoptic hypothalamic optic neuron. Okay, so any infections, any inflammation and any medication or any other related inflammatory related mediators, it is going to thermogenesis leading to our body temperature uncontrolled. So, infection, it is going to release microbial products, that is lipopolysaccharides, and it causes mononuclear cells and other cells and our toll receptor TLR4 and tumor necrosis factor, interleukin 1 and interleukin 6. So, pyrogenic, which is going to release cytokines which are released, these inflammatory mediators, it is going to act upon the blood vessels and once again vasoconstriction and followed by shivering and other mechanisms does happens. So, either inflammation, your mononuclear cells, it is going to release and prostacyclin PGE2 and your neural pathways like vagus nerve is going to be stimulated and in turn it is going to cause EP3 neurons which are warm sensitive and thermoeffectors are going to be released. Otherwise, we have got local infection, local inflammation and lipopolysaccharides which are going to release. Blood-brain barrier is there. So, once again your thermogenesis can happen in these people. We have got your preoptic hypothalamic anterior horns, this thing once again is going to cause a thermogenesis. Definition of fever. Okay. Fever is defined as the elevation of body temperature that exceeds normal daily variation and occurs in conjunction with an increase in the hypothalamic set point from 37 degree to 39 degree centigrades or rise of core body temperature. Fever is a pyrogenic mediated rise in body temperature above the normal range. So, what are the things which can lead to fever? Infections, inflammation, microbial toxin related release of your lipopolysaccharides, gram negative bacteria going to release your lipopolysaccharides or interleukin 1, interleukin 6, tumor necrosis factor, all these things. So, your monocytes, macrophages and cytokine endothelial cells is going to release the pyrogenous cytokines. So, it is going to hypothalamic endothelium going to get, so it is going to act upon this releasing PGE2 and cyclic AMP, elevated thermoregulatory set point, heat conservation and heat production, and later results in fever. Hyperthermia versus hyperpyrexia. So I already said you people about a normal body temperature. Now what is this hyperthermia? What is hyperpyrexia? Hyperthermia is the elevation of body temperature due to failed thermoregulation, typically occurring the body temperature exceeds 37.5 degree to 38.3 degree centigrades, that is 99.5 to 100.9 degree Fahrenheit. Whereas hyperpyrexia, extreme elevation of body temperature usually above 41.5 degree centigrade, that is 106.7 degree Fahrenheit, often resulting in severe infection or heat stroke. Hyperthermia symptoms include dizziness, headache, nausea, which can often be managed by cooling measures and hydration. Hyperpyrexia, it includes confusion, seizures, loss of consciousness requiring immediate medical attention. Hyperthermia generally less severe and can be treated without immediate medical intervention if caught early, whereas hyperpyrexia, it often necessitates antibiotics and intravenous fluids to bring temperature down quickly. This is fever of unknown origin definitions way back in era in 1907, Cabot's definition. So characterized by the fever which is lasting for 2 weeks or longer as long fever. This is early definition stage of understanding prolonged fevers. Whereas in 1961, Petrodop's and Besson criteria defined as fever of unknown origin as the temperature of 38.3 degrees centigrade or higher for at least 3 weeks without diagnosis despite 1 week of inpatient investigation. Now the evolution of criteria of pyrexia of unknown origin or fever of unknown origin. So what is it? So Durack and Street revised the criteria, shortening the investigation period. So fever of unknown origin is defined as fever for more than or equal to 38.3 degrees centigrade, that is equal to 101 degree Fahrenheit on at least 2 occasions. Illness duration of more than or equal to 3 weeks. No known immunocompromised state. Diagnosis that remains uncertain after thorough history taking, physical examination and following obligatory investigations. So what are the obligatory investigations which you require in the pyrexia of unknown origin? So commonest investigation is complete blood count. Complete blood count. Your ESR levels, erythrocyte sedimentation levels and C-reactive protein levels, and we have got electrolyte levels, serum electrolyte levels. We have got blood urea, serum creatinine. We have got liver function test, lactodehydrogenase, creatine kinase, ferritin, anti-nuclear antibodies and rheumatoid factors, protein electrophoresis, urine analysis, blood culture and urine culture, chest X-ray, abdominal ultrasonography and tuberculin skin test or interferon gamma release assay. All these are all most important investigation for a pyrexia of unknown origin we are going to get. Categories of FUO. So we have got 4 categories of pyrexia of unknown origin. One is classical pyrexia of unknown origin, nosocomial and immunodeficiency associated pyrexia, and travel associated fever of unknown origin. So classic FUO is defined as a fever of more than temperature equal to or more than 38.3 degrees centigrade or higher, lasting for at least 3 weeks without a diagnosis despite 1 week of inpatient investigation. Whenever the patient is admitted to inpatient, if a patient is admitted, so despite even 1 week of investigation, patient's fever is not coming down, or if a patient is temperature is more than or equal to 38.3 degrees centigrade, so for at least 3 weeks, then we are going to say it's a classical pyrexia of unknown origin. Next is nosocomial or hospital, nosocomial pyrexia of unknown origin. So nosocomial FUO develops in a hospitalized patient, so can be caused by infections such as bacteremia, pneumonia or a catheter associated infection. So immunodeficiency associated FUO. So this category includes pyrexia of unknown origin in patients with underlying immunodeficiencies where causes may vary based on the type and extent of immunosuppression. So most important one more is travel associated pyrexia of unknown origin. So travel associated FeO encompasses fevers arising from infections which are linked to travel, including malaria and entry fever, particularly in the tropical regions. So category based definitions, as I already said you people. So classical FeO, temperature of more than or equal to 38.3 degree, that is 100.9 degree Fahrenheit, recorded on several occasions for more than 3 weeks despite 3 outpatient clinical evaluation, 1 week of intensive outpatient investigation, or 3 days of hospital based evaluation. Healthcare associated pyrexia of unknown origin. So most important, we have got ICU patient, non-ICU patient, post-operative patient. So ICU patient, temperature of more than 38.3 degree recorded on several occasions in an ICU patient despite more than or equal to 3 days of investigation. Fever must not have been present or incubating on admission. That is ICU patient. Non-ICU patient, same definition for as of ICU patient, except patient is hospitalized but not critically ill. Post-operative patient, so same definition for as I said you, ICU patient, except fever is usually defined as temperature equal to or more than 38 degree centigrades. So pyrexia of unknown origin in immunocompromised patients, neutropenic patients, so temperature of more than or equal to 38.3 degrees centigrades or more than 38 degree sustained over 1 hour period, recorded on several occasions over at least 3 days despite appropriate antimicrobial therapy. Neutropenia is defined as less than or equal to 500 neutrophils per microliter or impending fall to that level within 48 hours. Patients with HIV and CD4 count less than 200 cells per microliter. So temperature of more than or equal to 30.3 degree recorded on several occasions for more than 3 weeks for outpatients or more than 3 days for inpatients despite appropriate evaluation. Travel associated FeO, yes, temperature of more than 38.3 degree associated recorded on several occasions for more than 3 weeks despite 3 outpatient clinical evaluation, 1 week of intensive outpatient investigation or 3 days of hospital based evaluation in a patient who traveled to another country, typically within prior 12 months. So definitions of FeO vary. An overarching definition of FeO is fever in the absence of identifiable cause despite reasonable evaluation and either the inpatient or outpatient setting. The fever must persist longer than typical or suspected self-limited conditions such as common viral illness. A specific temperature threshold to define fever is debatable as well. Okay, okay. Etiology and epidemiology. Up to half of all infections in patients with FeO outside Western nations are caused by Mycobacterium tuberculosis. So, which is a less common cause in Western Europe and also in United States of America. So, in Western cohorts, non-infectious inflammatory diseases, so including autoimmune, autoinflammatory, and granulomatous diseases as well as vasculitides, form the most common cause of pyrexia of unknown origin. So, this is a chart which is dissipating for you people. What are the commonest causes of pyrexia of unknown origin? So, it is suggesting you people, so 36% are infections, almost 24% are your neoplasms, okay, and your 21% is connective tissue disorder, miscellaneous 6%, undiagnosed is also almost 24% is still there. The widespread use of antibiotics and especially the availability of new diagnostic technique, the proportion of causes caused by intra-abdominal abscesses and tumors, for example, has decreased because of earlier detection by CT and ultrasonography. So, in addition, infective endocarditis is also a less frequent cause of your pyrexia of unknown origin because evaluation of blood cultures and other things are made. Okay, 2D echocardiography and evaluation of blood cultures are made infective endocarditis as a less commonest cause. A less aggressive diagnostic approach may be useful in clinically stable patients once diseases with immediate therapeutic or prognostic consequences have been ruled out. These are all the differential diagnosis of pyrexia of unknown origin. Bacterial, we have got abscesses, intra-abdominal, intrathoracic, central nervous system, dental, actinomycosis, cat scratch disease, chlamydia, ehrlichiosis, endocarditis, leptospira, listeriosis, mycobacterium, Neisseria, nocardiasis, and osteomyelitis or septic arthritis. And we have got pelvic inflammatory diseases and periodontitis are other things. Fungal, we have got blastomycosis, candidiosis, coccoidomycosis, and histoplasmosis. Viral, we have got cytomegalovirus, we have got Epstein-Barr virus, hepatitis, HIV, and dengue fever. Non-infectious inflammatory diseases, we have got wide variety of things under which we have got rheumatological causes, connective tissue disorders, like we have got ankylosing spondylitis, antiphospholipid antibody syndrome, autoimmune hemolytic anemia, autoimmune hepatitis, we have got Behçet's disease, cryoglobulinemia, we got dermatomyositis, Felty syndrome, gout, and mixed connective tissue disorders. You got polymyositis, pseudogout, reactive arthritis, relapsing polychondritis, rheumatic fever, rheumatoid arthritis, and Sjogren's syndrome, systemic lupus erythematosus, and Vogt-Koyagy-Harada syndrome. Vasculitic syndromes, yes, they are also most important cause of your FUO. You got allergic vasculitis, eosinophilic granulomatosis with polyangiitis, and giant cell vasculitis, polymyalgia rheumatica, and granulomatosis with polyangiitis. Hypersensitive vasculitis, Kawasaki disease, polyarteritis nodosa, and Takayu's arteritis, and urticarial vasculitis. Granulomatous diseases, we have got idiopathic granulomatous hepatitis and sarcoidosis. Autoinflammatory syndromes, we have got adult onset Still's disease, Blau syndrome, cryopyrin associated periodic syndromes, Crohn's disease, and deficiency of interleukin 1 receptor antagonist, familial Mediterranean fever, and hemophagocytic syndrome, hyper IgD syndrome, juvenile idiopathic arthritis, and pyrogenic sterile arthritis, pyoderma gangrenosum, and acne, or periodic fever, optus stomatitis, pharyngitis, and adenitis. Recurrent idiopathic pericarditis and synovitis acne, pustulosis, hyperostosis, osteomyelitis, and Sisner syndrome. TRAPS, tumor necrosis factor receptor associated periodic syndrome. Hematologic malignancies, amyloidosis, angioimmunolymphoma, you got Castleman's disease, Hodgkin's disease, multiple myeloma, myelodysplastic syndrome, myelofibrosis, non-Hodgkin's lymphoma, plasmacytoma, systemic mastocytosis, vaso-occlusive crisis in sickle cell disease, malignant histiocytosis, leukemia, and lymphocyte granulomatosis. Solid tumors, most of the solid tumors metastasize and it can cause fevers. Commonly we include breast carcinoma, colonic carcinoma, lung carcinoma, and pancreatic and renal cell carcinoma. Benign tumors, angiomyolipoma, cavernous hemangioma of the liver, craniopharyngioma, necrosis of dermal tumor in Gardner syndrome. Miscellaneous, adrenal insufficiency, aortic dissection, aseptic meningitis, cirrhosis of liver, complex partial status epilepticus, drug fever, Hashimoto's encephalopathy, pulmonary embolism, and subacute thyroiditis and ulcerative colitis. Thermoregulatory disorders, we got central as well as peripheral. Central, brain tumor, cerebrovascular accident, encephalitis, and hypothalamic dysfunction. Peripheral, we got anhidrotic ectodermal dysplasia, exercise-induced hypothermia, hyperthyroidism, and pheochromocytoma. So, infectious causes, we got atypical manifestations, presentations of endocarditis, diverticulitis, and vertebral osteomyelitis, extrapulmonary tuberculosis, abdominal and pelvic abscesses, dental abscesses, aspergillosis, candidiasis, amoebiasis, hepatitis A, B, C, D, and E, and HIV infection. More commonest cause in infections are, these are the main things. Non-infectious inflammatory diseases, yes, as I already covered, adult onset, Still's disease, joint cell arteritis, large village vasculitis, and polymyalgia rheumatica, systemic lupus erythematosus, sarcoidosis. Malignancies, although most tumors can present with fever, very malignant lymphoma is the far most commonest diagnosis in the patient with that neoplasms. Miscellaneous, so acute disseminated encephalomyelitis, adrenal insufficiency, aneurysms, pulmonary embolisms, thrombosis, ulcerative colitis. Thermoregulatory, I already covered you. Brain tumor, central brain tumors, cerebrovascular accident, and encephalitis. Peripheral hyperthyroidism, pheochromocytoma, and anhidrotic ectodermal dysplasia. FUO is usually not due to rare diseases, but due to atypical presentation of common diseases. So, whenever we are evaluating a patient of pyrexia of unknown origin, it is better to think about a common disorders which are common with presenting with a rare manifestations. So rethink about infectious causes, inflammatory causes, possible in next later is any cancer, neoplasms, and other things. So most important in a pyrexia of unknown origin patient is reliable history. So history taking is an art. When we are completely taking a correct history, so that will give a most important what are the things which are required for a physical examination. So history taking and physical examination and a systemic follow up as well as by the investigation level. Then later we are going to come to a conclusion what are the differential diagnosis and diagnosis. So the most important step in diagnostic workup is search for a potential diagnostic clues through a complete and repeated history taking, physical examination, and obligatory investigations. History, it should include fever pattern, whether it is a continuous fever, intermittent fever, or a remittent fever, duration of the fever, as well as previous medical history, present and recent drug use, family history, sexual history, country of origin, and recent and remote travel history, unusual environmental exposure, as well as that of travel or hobbies, and animal contacts. So each fever of unknown origin category has a clinical hallmarks. For example, usually malignant or neoplastic disorders are associated with that of early anorexia and significant weight loss. So infectious fever of unknown origin, chills are common, but weight loss is less pronounced and anorexia will happen late. So excluding vasculitis, synovitis is a rheumatic inflammatory hallmark. While hallmark features suggest particular fever of unknown origin categories. So some findings essentially eliminate a fever of unknown origin category. For example, Rigers eliminate rheumatic and inflammatory category of fever. Complete physical examination is required for the patient. So with a special attention to head to toe, starting from eyes, lymph node, temporal arteries, liver, spleen, all the systemic body organs should be examined very particularly. So any sites for previous any site of previous surgeries has been done. So anyway sepsis is there, just to try to rule out the patient with a pyrexia of unknown origin. So any surface laceration, any wound, cuts, simple cuts to this thing. So mucous membrane, any lacerated wound is there, cuts is there, just go through these things. So before diagnostic test is important, what is important is you go to antibiotic and glucocorticoid treatment, where the patient has already started to receive any antibiotic treatment or steroid. Patient has already received a first or second dose of steroid, which can mask so much of diseases. That is why we are very much bothered. So history should be very thorough, and later we have to go for a physical examination. So what are the examination points which are often missed in our day-to-day life is per rectal examination. So Perrectal examination, scrotal examination, pervaginal examination, and pap smear, hepatosplenomegaly, and lymphadenopathy, and skin rashes, or breast examination, dental examination, and thyroid examination. So, all the body parts, most importantly, perrectal, scrotal, as well as pervaginal and pap smear, hepatosplenomegaly, as well as lymphadenopathy, skin rashes. So, females, breast examination, as well as dental examination and thyroid examination are very much important. Potential diagnostic clues. What are these? Potential diagnostic clues are all localizing signs, symptoms, and abnormalities which are potentially pointing towards a diagnosis. There are certain important things, signs and symptoms in the patient which are potentially making us to go to a diagnosis towards the patient. So let us rethink which are the commonest OPD patients or IPD patients which we encounter in day-to-day life. So for an example, thyroid disorder is one of the commonest endocrinological emergencies which is going to land up in hyperthyroidism. What are the things? Fever will be there. Patient will come with a fever, patient will come with a throat pain as well as a tachycardia. So suspect hyperthyroidism. Diabetes mellitus. So look for any intra-abdominal abscesses and dental abscesses. Rapid weight loss. So somebody is saying, I lost 6 kgs in last 3 months. I lost 10 kgs in last 6 months. So is suspect. Possibly, maybe history of any malignancies is there. Infections, potentially in Indian setups. Tuberculosis, maybe history of HIV. Those things we will be missing towards it. Cytopenias. So always try to do peripheral smears to rule out for leukemias. Anemia and weight loss and fever. Look for gastrointestinal malignancies. Headache and mild fever. Tubercular meningitis. So TB meningitis is a fever, headache, neck stiffness. So try to rule out tubercular meningitis. And cattle rares, brucella should be kept in mind. So these are all potential diagnostic clues. Thank you.